continue on in the cardiac cycle, slide 7, where I left off on Tuesday. I wanted to warn you that one student in this group requested a study guide for next Tuesday. I've just about got that put together, so that'll be going up on my SCM course site. Deepwater, they can help drive questions at the review session tomorrow. Now, where we left off, I had introduced you to the basics of the cardiac cycle. You should have the idea that blood is ejected from the left ventricle during ventricular systole. In the resting cardiac cycle, the left ventricle refills during ventricular diastole. We can divide these parts of the cardiac cycle, ventricular systole and ventricular diastole, into subparts, subphases, as indicated in this diagram. So we traditionally start off the cardiac cycle with atrial systole, the atria contract, and then the ventricles contract. Once we get into ventricular contraction, and really we're into that plateau phase of the ventricular cardiac myocytes, so letting calcium come in, ventricular cardiac myocytes are squeezing harder and harder. And what's shown here in red on this graph, right at the very beginning of ventricular systole, the pressure of the blood in the left ventricle is rising dramatically. That's what's being plotted here, is pressure of the blood in the left ventricle, millimeters mercury pressure, building up as the walls of the left ventricle are squeezing on the blood that's in the left ventricle. Now, as soon as you start squeezing and pressurizing that blood, you don't want that pressurized blood to go back into the left atrium. So the mitral valve closes as soon as that pressure starts to increase in the left ventricle. Now, at that same time, when the mitral valve closes and we're into ventricular systole, the aortic valve is also closed. So during this first part, the skinny phase, subphase of ventricular systole, there's no place for the blood to go. You're squeezing on the blood in the left ventricle, you're pressurizing, but the blood is trapped in the left ventricle. So really the only thing that's happening is you're having a dramatic increase in the pressure of the blood. Now where we're going to get to is what's called pressure volume loop. And pressure volume loop, by the way, there'll be 3 of these on the exam next week. So you need to know your pressure volume loops. In a pressure volume loop, we're summarizing all the changes in pressure in the blood in the left ventricle and volume of blood in the left ventricle in one handy-dandy diagram. So we plot volume on the horizontal axis, pressure of the blood in the left ventricle on the vertical axis. So I'm talking about here in this first phase of ventricular systole, when we're squeezing on the blood in the left ventricle, but there's no place for the blood to go. If we plot that on a pressure volume loop, the pressure is just increasing and there's no change in volume. When there's no change in volume, we call that isovolumetric. Same volume. You need to know that jargon. So it's more Greek. Mr. Isosceles, if I started torturing you, then look for it. An isosceles triangle. So going from point 2 here in pressure volume loop to point 3, the only thing that's changing is the pressure. The pressure is increasing because you're squeezing on the blood and you're pressurizing. Volume doesn't change because both the mitral valve and the aortic valve are closed during that part of ventricular systole. Now, as soon as the pressure of the blood in the left ventricle rises above the pressure of the blood out in the aortic valve pops open, and then blood starts leaving the left ventricle and going out into the aorta. So right here at the end of isovolumetric contraction, it's labeled the aortic valve opens. And then you're actually into the ejection part of the cardiac cycle when blood is being ejected from the left ventricle and going out into the aorta. pressure of the blood in the left ventricle continues to increase for the first part of the ejection part of the cardiac cycle, because you're still in the plateau phase for your ventricular cardiac myocytes. They're still letting in more calcium, and they're still squeezing harder and harder. So you're still increasing the pressure of the blood. The solid red line here is the pressure of the blood inside the left ventricle. The dotted line here is the pressure of blood out in the aorta. Now, as long as the aortic valve is open, there can't be a very big difference in pressure between the pressure of the blood in the left ventricle and the pressure of the blood out in the aorta. You guys have seen the aortic valve? I've never actually looked at an aortic valve. You guys have seen the aortic valve. When it's open, it's a big hole there. So there's essentially no resistance between the left ventricle and the aorta. So the pressure of blood in the left ventricle is almost exactly the same as the pressure of blood out in the aorta. The aortic valve is open. Now, eventually, you reach the point where your ventricular cardiac myocytes start coming out of the plateau phase. Remember, way down at the bottom of this diagram, that's when you're into the T wave. So the T wave of the electrocardiogram is here during what we call the reduced ejection phase. But during reduced ejection, you're starting to lose contractile strength because your ventricular cardiac myocytes are all ending their plateau phase and they're pumping calcium out. So they're not squeezing as hard anymore. So during reduced ejection, the pressure starts to drop. As soon as the pressure of the blood in the left ventricle goes below the pressure of the blood out in the aorta valve pops shut to prevent blood from flowing back from the aorta back into the left ventricle. So you need to know these valve events, and I will hold you responsible for these valve events. You need to know the mitral valve closes at the beginning of isovolumetric contraction or at the beginning of ventricular systole. The aortic valve opens right when you're going into the ejection phases. So the aortic valve opens when you pressurize the blood enough. The pressure of the blood in the left ventricle goes above the pressure of the blood out in the aorta. And then the aortic valve closes as soon as the pressure of the blood in the left ventricle drops below the pressure of the blood in the aorta to prevent blood from leaking back into the left ventricle from the aortic question.
Yeah, I'm sorry. Do you mind just explaining the plateau phase and the relationship between the ventricular systole and all of that? I think I missed it.
Remember, the QRS complex, the peak of the R wave is right here at the beginning of the ventricular systole.
Yeah.
So that's the beginning of the plateau phase, and then sometime over here, all ventricular myocytes are ending their action potentials. So the plateau phase is basically from here to here sometimes. That's when calcium's coming out.
Okay, so as soon as we're starting this reduced ejection, then we're beginning to
The T wave is right here.
Plateau
If you go
phase.
down to the bottom of this diagram. So that's when the ventricular action potentials are ending.
Okay, that makes sense. Great, thanks.
Line is that ventricle versus the aorta?
Solid line is the pressure of blood in the ventricle. This dotted line is the pressure out in the aorta. This dotted line down here is the pressure of blood in the left atrium. So when you start squeezing and the pressure of blood in the left ventricle goes above the pressure of the blood in the left atrium, the mitral valve closes to prevent blood from flowing back from the left atrium, from the left ventricle into the left atrium. Now, when the aortic valve closes, that's the end of the ejection part. We divide the ejection part of the cardiac cycle into rapid ejection and reduced ejection. Rapid because most of the blood leaves during the first part of ejection here, and then when you're squeezing weaker, you have less blood leaves during reduced ejection. But you're still pushing blood out during reduced ejection. As soon as the aortic valve closes, both of your valves at either end of the left ventricle are closed again. The mitral valve is still closed, the aortic valve closes, so then we enter into another isovolumetric relaxation phase. So remember, we started out, when we started squeezing, we had isovolumetric contraction and the pressure increased greatly. Then we have our ejection phase. During the ejection phase, pressure peaks and then starts dropping off, and the volume of blood in the ventricle decreases. Now, what's this difference in volume between this volume and this volume? What do we call that volume difference?
Stroke volume?
Yeah. Think about it. This volume of blood, we're decreasing from a large volume here to a small volume here. This is our end diastolic volume. That's the maximum volume of blood loaded into the ventricle. Then you start systole, right here. Squeeze out blood during systole, during the ejection phase. What do we call this volume here? That's the end systolic volume. So the difference between the end systolic volume and the end diastolic volume is the stroke volume. That's the whole point of the heart, is to squeeze, push blood out, inject blood out into the aorta to maintain cardiac output when you get stroke. Then, at the end of the ejection phase, when the aortic valve closes, because pressure is dropping in the ventricle cells are all at the end of their action potentials. They're all pumping calcium away from the troponin. Actin, myosin, phosphorus cycling is ending. You're not squeezing anymore. You've got the left ventricle relaxing. During that time, the pressure drops dramatically. It's an isovolumetric pressure drop because both the mitral valve and the aortic valve are closed. There's no change in volume of blood in the ventricle. So the only change during that part of the cardiac cycle is big pressure drop. From 0.4 here to 0.1. So look at the big pressure drop here. Now eventually, the pressure of the blood in the left ventricle, as the solid line is, drops below the pressure of the blood in the left atrium. The dotted line here is the pressure of blood in the left atrium. As soon as that pressure of blood in the left ventricle drops below the pressure of blood in the left atrium, the mitral valve opens, and then blood starts flowing from the left atrium into the left ventricle, and you're into what we call the refilling part of the cardiac cycle. First part of refilling is called rapid ventricular filling, because that's when the greatest rate of blood flow from the atrium into the ventricle occurs. And once most of the blood is flowed into the ventricle, then you have a reduced rate of ventricular filling, but you're still filling during this period of time. Remember, in the resting cardiac cycle, refilling the left ventricle takes place during diastole. It's a passive process. The heart is relaxed. You're refilling, and on the pressure volume loop, this is what's happening during that refilling part of the cardiac cycle. These two subphases. You're refilling the volume of blood in the ventricle. It's filling up again. You're coming back to your end diastolic volume. There isn't much pressure change during ventricular refilling. It comes up a little bit towards the end as you're filling up the ventricle. It's stretching out. Pressure's going up a little bit as you're filling up the left ventricle, but not very dramatic. Not until action potential spread through the ventricle again, and you're into systole. You start squeezing on the blood in the ventricle, and then you're into ventricular systole. So we could label this graph, and I don't know the best way to do this. I want to say all the way from 0.4 over here, all the way over here to 0.2. This is all ventricular systole. We've got three subphases in ventricular systole. There's the isovolumetric contraction, there's the rapid ejection, and there's the reduced ejection. So systole is all the way from 0.2 to 0.4. Diastole is all the way from 0.4 down to 0.2. So we could label from 0.4 all the way over to here. This is ventricular diastole. So in pressure volume loop, we've divided the cardiac cycle up into segments. First division, we've got diastole is from 4 to 1 to 2. Ventricular systole is from 2 to 3 to 4. And we can further subdivide. This is the isovolumetric contraction. This is the isovolumetric relaxation. That's right at the beginning of ventricular diastole, when the ventricle is relaxing and the pressure is dropping. Question?
Yeah, so see how there are two dotted lines on this graph?
Yeah.
I
Look, they're labeled. This one is the pressure in the aorta. This is the one pressure in the atrium.
Okay.
Pressure in the atrium never goes high when you're at rest. Even when the atrium contracts, look at it. When the atrium contracts, the pressure of the blood in the left atrium rises a little bit.
Right.
But atria are wings. That's the technical term. They just don't squeeze very hard, particularly when you're at rest. So during atrial systole, you pressurize the blood in the atrium a little bit. Also, here during the ejection phase, when you've got the mitral valve that's closed, the mitral valve is closed all the way from here to here. When the mitral valve is closed, blood continues to flow into the left atrium. Where's it coming from? It's coming from the pulmonary circulation. So blood continues to flow in, and the pressure rises. It's just like filling up a balloon. As that blood coming into left atrium fills it up, the pressure rises a little bit. Eventually, when the pressure of the blood in the left ventricle drops below the pressure of the blood in the left atrium, that's when the mitral valve opens again, and then you're into refilling the left ventricle. Now, you're going to have to spend some time thinking through the cardiac cycle. And there's two ways you can do this, and you need to do them both for exercise. It's just like if you're getting ready to run a marathon, you can do different types of exercises. Get your muscles ready, get your stamina up. So spend time looking at this diagram. You need to know these subphases, the valve events, when they occur. You need to know how the pressure changes in the left ventricle. And then you're going to have to spend time looking at pressure volume loops. And this is exercise. You've got the whole cardiac cycle here showing the major pressure and volume changes. In this diagram, you don't see the volume changes. Remember where the volume changes are in this diagram. This is the figure 13.3 from the Rhodes textbook. You got to go all the way down here. Here's the graph for the volume changes. We went through this the other day. Pressure volume loop, you've got the volume changes and the pressure changes all in one handy-dandy graph. So this isn't all going to sink into your noggin just by listening to Schmidt talk you through it. You're going to have to spend some time thinking this through. Make use of the homework worksheet. Is there anybody that didn't get the homework worksheet? Also, I posted on the course site a copy of this graph from the Rhodes textbook, and along the right side, points, topics that you should understand from the graph. So spend some time looking at that. So here is stepping back so you can see the volume graph here. This is the volume of blood in the left ventricle that we looked at previously. This is the pressure changes in the left ventricle that we were just looking at. In between, sandwiched in between, this is the graph of cardiac output in meters per minute. And it should make sense to you that you have cardiac output during the ejection part of the cardiac cycle. So here's rapid ejection, reduced ejection. And this is showing that the rate of blood ejection from the left ventricle peaks and then starts dropping off as you get into the T wave. Go down just a little bit further, you'll see the electrocardiogram, T wave is right here. That's when the ventricular action potentials are ending. You're no longer squeezing as hard, so the ejection of blood drops off. You can see, what was our typical value for cardiac output in a resting individual? We had up here on Tuesday. Like 5 liters per minute is a good textbook value. Look how high it can go during the peak of ejection. It's over 45 liters per minute for a short time here. So when that aortic valve is open and you're really squeezing the left ventricle, the blood's really squirting out of the left ventricle, going out into the aorta at a fast rate. So for a short period of time, part of the cardiac cycle, the rate at which blood is leaving the ventricle and going into the aorta is very fast. So again, the pressure volume loops summarize both the pressure changes, and you can see the dramatic pressure changes are during the isovolumetric phases. Isovolumetric contraction when pressure is increasing, isovolumetric relaxation when the pressure is dropping. So those vertical lines in the pressure volume loop are the dramatic pressure changes. The dramatic volume changes come during the ejection phase. It should make sense to you. When you're ejecting blood, you're going to have a big change in volume of blood in the ventricle. You're squeezing all that blood out into the aorta. So you're going from your end diastolic volume, the maximum volume of blood in the ventricle, you squeeze, blood leaves, volume drops, you get to the end systolic volume after you're done squeezing. Then during diastole, you're into ventricular filling. This is the rapid refilling phase. Look at the slope of the line. It's a steeper curve. It starts slowing down as you get into reduced ventricular filling. Now, it freaks students out that the atria are so unimportant in the resting cardiac cycle, but this is zooming in on that first subphase of the cardiac cycle, right at the beginning of our graph, year 13.3 in the Rhodes textbook. This is showing the volume of blood in the ventricle here. This is showing the pressure, solid line pressure in the ventricle, dotted line pressure of blood in the atrium. During this time, during atrial contraction, the mitral valve is open. So if you're squeezing on the blood in the atrium, it's going through that big hole of the mitral valve. The pressure is essentially the same between the atrium and the ventricle because there's no resistance. There's no significant resistance when blood is going through the open mitral valve. The pressure increases as the atrium squeezes the blood. So we've got increase in pressure. It's relatively modest. You might get a 10 millimeter mercury increase in pressure in the blood when the atrium squeezes. Because the atria just don't work very hard. Look at the volume of blood that goes into the left ventricle when the left atrium contracts. It's not much, maybe 5 milliliters, 10 milliliters. Most of the blood returning into the ventricle occurs during diastole when the heart's depressed. It's just passive flow of blood going from the vein into the atrium, into the ventricle. So there's not much left for the atrium to do when it gives this little squeeze. Now this changes completely during exercise. During exercise, the atria become much more important. But you guys are taught the resting cardiac cycle. That's what we're looking at. In the resting cardiac cycle, just a small fraction of the blood that gets loaded into the left ventricle occurs during atrial systole. Now, this boundary here between atrial systole and ventricular systole, this is our landmark point for electrocardiogram. The peak of the R wave is right here at this boundary. So we take the peak of the R wave to be the beginning of ventricular systole. And remember, the first phase of ventricular systole is this isovolumetric phase, when the mitral valve closes. The aortic valve is still closed, so you're just pressurizing the blood by squeezing. So the pressure of the blood in the left ventricle increases dramatically. There's no volume change during isovolumetric phases. So that's this vertical line here in the pressure volume phase. It's the first phase of ventricular systole. So we say ventricular systole starts at 0.2 on the pressure volume wave. And this vertical line corresponds to the first subphase of ventricular systole, the isovolumetric contraction phase. As soon as that pressure, you're squeezing, you're building up the pressure in the left ventricle, as soon as that pressure goes above the pressure of the blood out in the the aortic valve opens, and then you're into the ejection phases. Here you can see, this is the graph for volume in the left ventricle. Volume decreases dramatically when you're squeezing blood out of the left ventricle and out into the aorta. During that time, there is a little bit of increase in pressure. You can see the pressure of blood in the left ventricle increases in this graph from about 80 to about 120 to reach your systolic pressure peak. So this is the 120 millimeters mercury systolic pressure peak that you measure when you're measuring somebody's blood pressure. It comes right at the peak of ejection of blood during the ejection phases. That peak is right at the boundary between rapid ejection and reduced ejection. And the pressure starts dropping because you're at the end of the ventricular action potentials. The aortic valve will close to prevent blood from leaking back from the aorta back into the ventricle. And that's the end of ventricular system. So going from point 3 to point 4 on the pressure volume loop, these are our two ejection phases, rapid ejection and reduced ejection. You're squeezing out your stroke volume of blood. You're peaking your pressure. This is your systolic pressure peak. And then that's the end of systole. And the aortic valve closes. And the walls of the ventricle are all relaxing because they've all reached the end of their action potentials. The T wave is right here, so all of ventricular action potentials are over. The next phase is our second isovolumetric phase, and this is the first phase of ventricular diastole. And there's no volume change, there's just big pressure drop as the wall of the ventricle is relaxing. And that's this vertical line in the pressure volume loop from 4 to 1. You're in the isovolumetric relaxation phase. Pressure drops. As soon as the pressure in the left ventricle drops below the pressure of blood in the left atrium, then the mitral valve will open up and blood will start flowing from the left atrium into the left ventricle. It doesn't require any contraction. This is in the diastole part of cardiac cycle. The atrium is relaxed. The ventricle is relaxed. So you're into refilling. Passive process, doesn't involve the heart defect. So this is the transition here. This is the point going from mitral valve opens up again. And you're into the refilling. Volume of blood in the ventricle increases quickly as soon as that mitral valve opens. So here's the graph showing how the volume of blood in the left ventricle increases dramatically during rapid ventricular filling and reduced ventricular filling. So as soon as the mitral valve opens, blood just comes dropping down from the left atrium into the left ventricle.
What is this preload?
Yeah. Now, more jargon. Who wasn't ready for more jargon? You know, you were all just waiting. Give us more jargon. These are two jargon terms that are used to describe how the heart functions unique to them. Preload, think about how a muscle works. You may not want to think about this at 8 o'clock in the morning, but physiologists will rip a muscle out of a lab animal like a lab rat and hang it up in a laboratory apparatus. So you've got one end of the muscle hanging, you can put weights on the other end, you can stretch it out. Remember the length tension relationship? You can stretch out a piece of muscle tissue, change its length with sarcomers, and then you can measure the way it contracts. So you can generate length tension relationship with a hunk of tissue, like a muscle tissue. Think about the heart as a muscle. Now the heart isn't hooked up to bones, it's not moving your skeleton around. The heart's job is to pressurize blood, make blood move. But think analogously to skeletal muscle tissue. If you have a piece of skeletal muscle tissue in the lab, physiologists do this, they hang weights on a piece of muscle tissue. So if you want to put a load on the muscle tissue, just hang a heavy weight on the end of the muscle. Then you get out your electrodes, stimulate the muscle to contract, the muscle contracts, and it's lifting the weight. So, concept of afterload is really the weight that a muscle can lift if you're dealing with skeletal muscle tissue. In the heart isn't working against the weight. It's not trying to lift the weight. What does the heart have to work against when it's pushing blood out into the aorta? What's causing resistance to movement of that blood? Would you have more resistance to moving blood out of the left ventricle into the aorta if the patient had chronic hypertension? The pressure of blood out in the aorta is high. Yeah. So for afterload, you want to be thinking arterial blood pressure. For a skeletal muscle, if I go over and I try to lift this table, the weight of that table is the load that my muscle is working against. For the heart, the load that the heart is working against when it's contracting, squeezing, and pressurizing blood and trying to push blood out into the arteries is the arterial blood pressure. If you have high arterial blood pressure, we say you have a high afterload. This is the problem of chronic hypertension. The heart has to work harder against that high blood pressure. High blood pressure out in the arteries is like a dam resisting the heart pushing more blood out into the arteries. So chronic hypertension, disease condition, physiologists call it a condition of high afterload. So it's jargon you need to know because hypertension is one of the big killers in this country. And the way physiologists talk about it, they're not happy to just say chronic hypertension. They're thinking about the struggle that the heart's having to work harder. This is why you end up with enlarged hearts in the cadaver lab. Hearts spend decades working against increased afterload, chronic hypertension. Now preload, what's preload? And notice what's said here. If you're thinking about preload, think about the Starling curve. Remember the Starling curve? What do we graph down here? We can graph end diastolic volume. If you load more blood into the heart, you're expanding the left ventricle. So you're expanding the left ventricle, you're stretching out the cardiac myocytes, you're optimizing the overlap between actin and myosin. You'll get increased stroke volume, you get increased contractility as you climb up the Starling curve due to putting more blood into the ventricle. So preload, be thinking end diastolic, and I'm going to write here volume. But think about it. As you load more volume of blood into the ventricle, is it going to be more pressurized? Yeah. It's like blowing into a balloon. As you blow up a balloon, pressure's increasing. So as you're loading more blood into the ventricle during refilling, during diastole, you're achieving a higher end diastolic volume. You're also, pressures are increasing a little bit. Look at our pressure volume graph here. See how this comes up a little bit? It's not a big difference, but pressure is increasing a little bit during refilling. The volume change is more dramatic. But unavoidably, there's also pressure increase. So if you're thinking preload, think about the volume of blood that's loaded into the ventricle just before it contracts. It's like what you've loaded in. It's the volume of blood that you've loaded into the ventricle. But when the ventricle starts contracting, that's what it's going to be squeezing on. So preload is a jargon term. You can look up the technical definition, and you can write that down on your worksheet. But conceptually, thinking about preload is a good thing.
You want to do preload.
If you have a high preload, you're climbing the Starling curve, you're going to get more forceful contraction. The cardiac output's going to be higher. So, this is one of the things I told you happens during exercise. Return of venous blood to the heart becomes more efficient, and you actually get an increase in end diastolic volume during exercise, which is good if you're climbing up the Starling curve. And you're getting bigger stroke volume, more cardiac output. Now we're going to have to do that story of why preload increases during exercise. We haven't got there yet. We'll take that on faith for right now. So an increase in preload is good. It's part of how we increase cardiac output during exercise. Increasing afterload, I'm going to write here hypertension. Bad. Bad afterload. If you chronically have high arterial blood pressure, for the heart to keep moving its 5 liters per minute of blood out into the arteries, the heart's going to have to work harder to get that 5 liters pushed out where the pressure's higher. So anyhow, most of the refilling of the ventricle occurs during diastole. A little bit more goes in during or back to atrial systole. A little bit more blood goes in. So most of your preload, most of your loading of blood into the ventricle occurs passively during diastole. Just blood flowing to the left ventricle from the pulmonary circulation into the left atrium, right into the ventricle. And that's good to build up a good preload. You're climbing up the Starling curve and you're getting ready for your next contraction. Counting down. Okay, so there is blood leaving the ventricle during both the rapid ejection and the reduced ejection. A little bit more goes out during that first part, during the rapid ejection. I will be subjecting you to Mr. Isosceles for the rest of our time together. And think about what isovolumetric means. Isovolumetric means same volume. It means unchanging volume. It means no volume change. So when Schmidt asks a question about when volume is changing, choosing an isovolumetric base, not a good strategy. So this is jargon. It's annoying, but it makes sense if you know breathing. Isovolumetric phases, there's two of them. There's the isovolumetric contraction when the pressure is increasing, isovolumetric relaxation when the pressure is dropping dramatically. Think about this curve. A vertical line on this curve means there's no volume. Okay. Counting down. I like choice 3. This changes during exercise. During exercise, think about your whole cardiac cycle shrinking. What really shrinks dramatically when you double your heart rate and you have half as much time for the cardiac cycle, diastole really shrinks down. So you don't have all that leisurely time for the passive refilling of the left ventricle. During exercise, the atrial contraction, atrial systole, becomes much more important. And most of your blood is squeezed down into the ventricle during atrial systole. But you guys are responsible for the resting cardiac cycle. During the resting cardiac cycle, almost all of the refilling is passive. Just 5 or 10 milliliters filling takes place during atrial systole. So choice 3 is the correct choice. Now,
Wait, so if this
for those of you who still don't like Mr. Isosceles, let's go through this again. If I'm asking when does refilling take place, that means you're having an increase in volume of blood in the ventricle. It isn't going to happen during the isovolumetric phase. So whenever Schmidt has a question, ask when does the volume of blood in the left ventricle increase or decrease? Don't choose one of the isovolumetric phases. They're just there as an example.
So, during exercise, so if this said during exercise, the choice would have been atrial diastole?
Atrial
Systole.
systole. It's when the atria, think about it, during exercise, the atria are going to refill while the ventricles contract.
Right, right.
So they're storing up blood while the ventricles contracting. Then when the atrium contracts, it squeezes that blood that it's stored up down into the ventricle.
Right.
So most of the blood going into the ventricle during exercise occurs during atrial contraction. The atria become very important in exercise. They're essentially useless and unimportant when you're at rest. That's why patients can have ventricular fibrillation, atrial fibrillation. And their atria can just be sort of quivering, not really squeezing in the coherent column. They're okay. You don't really need atrial contractions when you're at rest, but it's different during exercise. So work on getting used to these two jargon terms, preload and afterload. I want you to think, when you see preload, think about how much blood did I load into the ventricle just before it contracted. So think about the end diastolic volume. The more blood you can load into the ventricle just before the ventricle contracts, the bigger your cardiac output will be. Now we're going to do the story of how you get good return of venous blood to the heart and you can load up the ventricle. We haven't quite got there yet. So we're going to be coming back to this. One type of heart disease is that compliance issue. You can get stiffer ventricle. Think about it. If you had a diseased ventricle that was stiffer than normal, either because it had hypertrophy and had a really thick wall, or it had scar tissue that was fibrous and not very stretchable, it would be hard to fill up the ventricle during diastole. It's not as stretchable. So that's an issue in some types of heart disease when you lose the stretchability of the ventricle. And you can't achieve a preload, big preload as easily just because the ventricle doesn't stretch as easily. It's like you've gotten a stiffer latex balloon that's harder to blow up. So think about end diastolic volume and think about the need to stretch the ventricular walls when you're refilling. Look at the volumes of blood. This large volume of blood comes back into maybe 70 milliliters coming back in during a fraction of a second. When you're refilling the ventricle, you want the ventricle to be stretchable. It's relatively low pressures. That blood comes down from the atrium into the ventricle. You want the ventricle to stretch out as it's refilled. That optimizes the length of the cardiac myocytes, the overlap between actin and myosin, and gets you ready for a good squeeze at the next ventricular contraction. So filling more blood into the ventricle makes the ventricle larger and gives you more efficient pumping action because you're aligning the actin and myosin filaments off and you're coming up that length-tension relationship with cardiac myocytes. So we're going to have to deal with this issue of venous return of blood to the heart. We'll get to that, we haven't got to it yet. So we're going to have to combine the flow of blood through the whole circulation to get blood back to the heart efficiently. So you can maintain a good preload, a good volume of blood loaded into the ventricle where it contracts. Afterload is the opposite story. Getting a good preload, a large volume of blood loaded into the ventricle is what we want. Chronic hypertension is a chronic increase in afterload, and it makes the heart work harder. If you just increase arterial pressure, you'll automatically decrease stroke volume and decrease cardiac output. So a sudden increase in arterial pressure is like creating a wall out there. The heart has to work harder against. Now the heart can do that. It can increase its work that it does to keep pushing the blood out. And that's what leads to heart hypertrophy in large hearts. Patients that chronically have to pump blood, squeeze harder, make their heart work harder against a high afterload, a chronic hypertension condition. So increased afterload, chronic increase in afterload is chronic hypertension. And it's bad for the heart.
Wouldn't like acute lead to increased preload? Like the heart?
It can get complicated. So don't open that can of worms quite yet. We're getting there. We've got to hook the whole circulatory system up to our heart. Right now we're sort of looking at the heart in isolation. Yeah, we're heading there. I showed you this graph before. If you have hypertension, you're going to not be able to squeeze as much blood out as if pressure out in the aorta was a little bit lower. It's easier to squeeze the blood out. So if you have an increased afterload, an increase in arterial blood pressure, you're not going to be able to, if you do nothing to the heart, just have it contract the way it was contracting, and then you suddenly increase, you're not going to be able to squeeze as much blood out against that higher pressure. So your stroke volume will drop if you have a sudden increase in arterial blood pressure. So increasing preload increases stroke volume and increases cardiac output. Increasing arterial blood pressure, increasing afterload, decreases stroke volume and decreases cardiac output. Now, you need to know your positive and negative chronotropic effects for regulating heart rate. You need to know the positive inotropic effect of sympathetic stimulation for the heart. There is a small negative inotropic effect for the parasympathetic division. If you activate the vagus nerve and activate muscarinic acetylcholine receptors on cardiac myocytes, you'll get a small decrease in calcium entry through multiple calcium channels on the surface. It's a minor effect. So know the positive inotropic effect of sympathetic stimulation to the heart, letting more calcium come in. There is a minor negative inotropic effect. It's just a pure jargon question. Often when the answer's on the whiteboard, some people get their hopes up that we can get 100%. At 8 o'clock in the morning, my hopes rarely get that high. Studies have been done on students. A lot of students, their brain isn't really awake until 10, 11 o'clock in the morning. So the jargon that we use when we're talking about that pressure out in the arteries that the heart has to work against to push blood out there, is afterload. So an increased afterload, high pressure out in the aorta, it's a problem for the heart. It's like a dam preventing blood from flowing from the left ventricle out into the aorta. So we say in chronic hypertension, there's increased afterload, and it creates a challenge for the heart. The heart has to work harder to keep moving the same volume of blood out into the arteries. Okay, let's take a 10-minute break.